Hello and good morning, everyone. Welcome to one more lecture of neurology that is about headache. A very important topic. And in this topic, one of the thing about headache which I want to talk about is, headache can be uh, a very common, you can say, a cause for which, like the people they visit the ERs, emergency departments, or to their doctors. And the most common type of headache is called as tension headache. So, but headache can be uh, due to some reasons which can kill the patient. So we have to identify them. And if someone is coming in the ER with the complaints of headache, so we should not miss those causes. So let's start with overview. Headache, as we know, it is defined as the pain in the head that can be located everywhere. And headache is the most common neurological symptom. By the way, most common, many other things as well. And 80 to 90% of the general population have at least one headache and leave the service, of course. So, what is the pathophysiology behind headache? Like the brain itself is not sensitive to pain, but um, it is surrounded by the structures which are pain sensitive. Venous sinuses, meningeal arteries, cranial and spinal nerve, periosteum of the skull, the skin and subcutaneous tissue, head and neck muscles, the ears, eyes, teeth, and sinuses. So, now talking about what you can say the headache, the classification. So headaches can be like this one is International Classification of Headaches, second edition. I have taken this thing from there. So as you can see, the headaches have different causes. Like one of them is primary headaches, then there is secondary headaches, and then there are a third categories which is like cranial neuralgia, central primary facial pain, and other headaches. So of course, like primary, when no cause is found. So you can see over here the primary headaches, tension type headache, the most common one. Then migraine is there, cluster headaches are there, and you can say there are other autonomic cephalgias. And then the secondary type of headaches are they are attributed like you. There is some other cause. Very easy way, when we check any patient. So like any patient who comes to us, first of all we look for the primary causes, and uh, if you know how we take the history of headache, like not headache, like any pain symptom. Sorts are out Socrates, like any mnemonic you remember, like site, origin, timing, severity, aggravating factors, relieving factors, and associated symptoms. So we do same for the headache. So uh, you can see over here the secondary headaches, attributed to head and neck trauma, subdural hematoma, epidural hematoma, attributed to cranial or cervical vascular disorders like hemorrhage, infarction, subarachnoid hemorrhage. A very important thing, which can be very fatal, should not be missed, right? And these also should not be missed. Attributed to non-vascular intracranial disorders, tumors can be there. Attributed to substance or its withdrawal, like some drug withdrawal or some drug abuse, alcohol. Attributed to infection like meningitis, encephalitis, or abscess. Attributed to disorder of hemostasis. Headache or facial pain attributed to disorder of cranium, neck, ears, eyes, nose, sinuses, teeth, mouth, or other facial or cranial structures. And headache attributed to psychiatric disorder. These are like simply primary headaches are those, uh, either the exact cause is not known or simply uh, they are on their own. There is no secondary cause, and when the headache is due to some secondary cause, of course, like that classified as secondary headaches. And I international disease classification says like cranial neuralgias are also there, central and primary facial pain, and other headaches like cranial neuralgias and central causes of facial pain, or other headaches like cranial neuralgia, central or primary facial pains. Anyhow, Now, from a first lecture, I talk about a mnemonic, whenever we take the history, and I gave you that mnemonic for the pain, that is Sotsara, which I use, by the way. Then there is Socrates, and there is PQRST mnemonic. There are different mnemonics, guys, to take the history of uh, for the pain. Okay, so for example, someone who's coming and I'm asking, like, if what is the severity of the pain, and if the severity is too much higher, and someone is saying, like, it's the worst headache of my life and it feels like a thunderclap, things like this, I will suspect that, okay, maybe the patient have subarachnoid hemorrhage. Okay, so I can, like, I will quickly send him to for a CT scan or a lumbar puncture, which is a discussion itself. So to start, like, for example, whenever we take the history, we must have the primary thing in our mind what we are taking history for. So if it is about headache, I should know the causes of the headache, and I should never forget, like, the most common causes plus the most dangerous causes. Okay, so there are different mnemonics for headache, by the way. What I do, like, the person is sitting in front of me, so I will be talking about the site origin, radiation, and timing and severity and all this stuff. But how I remember the causes of headache is, first of all, talk about trauma, then think about the brain. There could be hemorrhage, there could be tumor. Uh, when it comes to hemorrhage or hematoma, so remember subdural hematoma or extradural hematoma or subarachnoid hemorrhage, a tumor. Then comes the forehead. So there is a cause called as giant cell arthritis, in which, like, temporal artery is the one which is uh, inflamed. Okay. Then there is eye causes, for example, cataracts and things like this. Frontal sinuses are there, frontal sinusitis, ethmoidal sinusitis, and all these things. Then nose problems. Then to talk about the mouth, then tooth problem can cause headache. Trigeminal neuralgia can cause headache. Then think about the ears. Ear problems can cause headache. And a book which I read in too much detail is John Murtagh, general practice book. It says, like, many of the causes of headache are basically, the clue is in the neck or the cervical vertebrae. So always check them as well. Very, very important thing. So the important thing is, uh, like, that's how I go. But for example, like, one more mnemonic for the headache is ER visit. ER visit, or emergency visit. So E is for eye. For example, it could be glaucoma, it could be sinusitis. R is for recurrent or chronic, recurrent migraine, tension, cluster, temporomandibular joint problem, cervical osteoarthritis, like the problem can be in the neck. V is for vascular. Think about subarachnoid hemorrhage, intracranial hemorrhage, temporal arteritis. I is for infections, meningitis, encephalitis. S is for systemic causes, anemia, anoxia, carbon monoxide, poisoning in the females, preeclampsia can give headache. I is for intracranial pressure. Think about tumor, hypertension, pseudo tumor, cerebri, and the last T is for trauma, concussion, or you can include that thing here, subdural hemorrhage or extradural hemorrhage. So this is also a mnemonic, guys. Anyhow, basically you need a lot of baseline knowledge whenever you are going to meet anyone with a headache. So as I told you, tension headache is very, very, very common thing, and many of us, we have tension headache. Sometimes due to hunger, sometimes due to overworking, sometimes due to stress. Very, very, very common. So that's why Never forget the most common, never forget the most fatal. And now it's not the way, like if you are working as a GP and, for example, the patients are coming due to headache and you are sending everyone for CT scan. That makes no sense. So on history, you have to identify the cause. Okay, what is the thing which is causing headache? So always think about the most common tension headache. Always remember that thing, that causes of headache, which basically are very disturbing for the patient. For example, migraine or cluster headaches. And always remember the dangerous one, like subarachnoid hemorrhage, like meningitis, like tumors. Okay, so always rule out subarachnoid hemorrhage. Anyone who's complaining worst ever headache with stiff neck, some problem with the level of consciousness. Okay, think about subarachnoid hemorrhage. For example, if there is fever with stiff neck and, for example, skin rashes there, think about meningitis. See, if they have like some problem with consciousness and there can be fever or some bad behavior or odd behavior is there, think about encephalitis. So never ever forget these things, right? So very 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 important, to take history and go in the same way. What is the character of the headache, what is the frequency of the headache, what is the duration of the headache, what are the associated features, what are the precipitating causes, what are the relieving causes, and always ask about the red flags. Always ask about the drug history, because many people, they get headache due to some medications use. Okay, so for example, when you are asking the history from Sorsara, what I will talk about, I will ask about the site, onset, like radiations, timing. um, Timing means duration or frequency, severity, then aggravating and relieving factors, and then associated features. For example, someone who is giving visual changes, associated features, change in mental status, nausea, vomiting, fever, signs of meningism, photophobia, phonophobia. Okay, so I will think about all these things. Okay, so uh, for example, many of the drugs, why I was talking about, like, always talk about the drug history, because the drugs like calcium channel blockers and even NSAIDs and certain anticoagulants give pain, headache. Okay, so what are the red flags? Any new onset of pain, which is very, very, very severe, which is very sudden, and especially when there is fever or the patient is immunocompromised, or if you are finding any neurological deficit, think about CT scans. Okay, you can say these are the patients we sent for CT scan to rule out anything which can kill the patient, by the way. Okay, now I will tell you the character of the things, of the headache. For example, okay, headaches, acute, subacute, and chronic, depending on the time, right? See, if you can see over here, the tension headache, which is the most common one, it feels like a band. It is a band like pain, dull band like pain around the head. Okay, whereas you can see the migraine or cluster headache, it's migraine, most of the time it gives pain unilaterally, one side, whereas cluster headache give the pain behind the eyeball or around the eyeball. Okay, so see, just by knowing what is the character of the pain, you can really see location of the pain. If you will see, pain is usually behind the forehead, in sinuses and the cheekbones. Cluster headache, as I told you, around the eye. Tension headache is a band like, and migraine is mostly unilateral. So that's the reason, it's very important to take the history carefully. So location of the pain is very important. And but like this one is talking about the same things which I told you, right? You can say unilateral, bilateral, ocular, or retroocular. Okay, like headache from intracranial mass lesion is focal. You can see over here ocular, retro, or auricular. Like they're talking about the eye problems which can cause pain. Then it could be bioccipital or bifrontal. Okay, band-like or occipital, of course. Like band-like is tension headache, and occipital disorder of the joints, muscle joints, and upper cervical spine could be there. These are showing you the location of the paranasal sinuses. Okay, this one is uh, herpes zoster infection, which appear in a dermatomal fashion. So, of course, like some of the nerve dermatome is damaged and see the vesicles. It's very painful, by the way. Okay, so common feature of post-herpetic neuralgia. First division, the ophthalmic division of the trigeminal nerve is the one which is affected in this one. Okay, so guys, what is the important thing? Simply always check the frequency. For example, uh, someone who is saying that he have pain for the last 1 year and he's office worker and the pain start in the afternoon times when he come back from the office, seems more like a tension headache. Someone who is saying that I have a headache which is recurrent, whenever it comes it stays for 2-3 days and it disturbs me a lot, it is on one side of the head, seems more like a migraine. But someone who have a sudden pain, severe pain, and he have other signs of rigid neck and all this stuff, so seems more like a subarachnoid hemorrhage. Okay, so someone who have a recent upper respiratory tract infection and the pain is above the eyes, seems more like a sinusitis. So like this way, duration gives us a lot of idea, like either it's chronic, it's progressive. For example, someone who is saying that he have pain early in the morning and whenever he bend forwards the pain increases and he have vomiting as well, forceful vomiting is there, think about increased intracranial pressure. Okay, so increased intracranial pressure, the pain usually become worse when the patient is waking, he's lying, he's bending forward, or he's coughing. And when we examined their eyes, we found papillary edema. Okay, so all these things are very important. So always check for the eye things, like glaucoma can be the cause. Always think about, always check the foreheads and all these things. Okay, always ask about the precipitating features. For example, if it is after trauma, so think about it could be some sort of hemorrhage inside. So in drug history, you must use, especially always use how much painkillers they use, because sometimes when the patients, the people, they use a lot of painkillers, and medication overuse can give you headache that is called as analgesic rebound. Okay, so uh, this is a very common type of headache, by the way. So always ask about all these features, whenever you are going to like take the history. Very, very, very important, guys. Okay, so this thing, and then see associated symptoms, fever, think about infections like meningitis, dyspnea, can be subacute infective endocarditis. As a result of that, there could be brain abscess. Visual disturbance again will tell you about ocular disorders or migraine, nausea, vomiting, increase intracranial pressure. So photophobia again will tell, like, guide towards migraine, acute meningitis, or subarachnoid hemorrhage. So always go in the same way, Swartz or Socrates, whatever you want to use, but always like never jump any step. So ipsilateral and with rhinorrhea and lacrimation, you can see this photograph. Here it is fine, but here it is not fine. Think about the cluster headaches. Uh, Recent weight loss, think about cancers or depression. Okay. Pulsating and throbbing pain is when you will ask the character of the pain. Okay. Site, onset, radiation, timing. So pulsating or throbbing means migraine, can be tension headache. Okay. But someone who have like this, like there is a continuous pressure on the head, seems more like a tension headache. So all things like this, guys. Okay. Trigeminal neuralgia is a very sharp, stabbing type of pain. Lancinating, or you can remember stabbing. Someone is stabbing. It is such kind of pain. Okay. So simply like you have to go through all through these, right? And so you can see like headaches from mass lesions are maximal on awakening, increase in severity over time. So if there is a tumor inside the brain, when the patient wake up early in the morning, they have pain. Cluster headaches awaken patient from sleep that is so severe. Tension headache develop whenever stressful situations occur, maximal at the end of the day. Migraine headaches are episodic, maybe worse during menses and females. So there are different, many kinds of headaches. Okay, so after taking history, okay, you can see over here migraine headaches, again the same thing. There is post lumbar puncture headache as well. Like after lumbar puncture, many people they feel pain. That's why, especially the females after childbirth, when they get subdural uh, anesthesia, they feel headache. Okay, by rapid changes in head position or by coughing, by sneezing intracranial mass. Okay, this one is condition exacerbating headache. By anger, excitement or irritation, migraine or tension headache. By stooping, bending forward, sneezing or blowing of the nose, sinusitis. So all these things, right, can can be the cause. So physical examination, guys. Again, I always say that go in a routine. Take the vitals, take blood pressure. Hypertension can be the cause. Hypotension can be the cause. Take temperature, because if there is fever, so think about infection, think about meningitis, think about encephalitis. Then you will go for Kerning signs and Brudzinski sign. Okay, so take the blood pressure. Hypertension can be in pheochromocytoma, subarachnoid hemorrhage, or early hypersensitive encephalopathy. And if someone who have chronic hypertension, it's a major risk factor for stroke. Then physical examination, okay, we always check BMI, by the way. It's not written over here, but what we say it is like body mass index, right? So someone who have less BMI or he's lose some weight in the recent times, so think about cancers or chronic infections, okay, or immunocompromised, or anyone who have cancers, or anyone simply who have weight loss, and anyone who is less than 5 or more than 50, and there is a new onset of headache. These are all red flags, and we go for the CT scans because we don't want to miss anything which can kill the patient. So after that, okay, this one is like talking about neurological examination, but I just want to add few things which I will add over here. Once you had done the weight check, then go for head head examination, eye examination, ear examination, nose examination, and throat examination. Okay, never forget this thing. Head examination means what you can find the signs of trauma, you can find the signs of infection. Eye, always check the front fundus to look for what? Papil papilledema, if it shows like there is an increase in intracranial pressure, right? For example, someone who have retinal hemorrhages or hypertensive retinopathy can be there. Retinal hemorrhages. Okay. So, or for example, you are finding red eye, conjunctivitis, glaucoma. Okay. So see, all when you will check the forehead, maybe you can found temporal arteritis or giant cell arteritis. Okay, arteritis. Okay, so check the sinuses for any sinusitis, right? Palpate them. Check the temporomandibular joint. Check the nose, as well as check the ears, because ear problems can also lead to headache. Check the cervical vertebra. And what to check in the oral? Check the teeth for any infections, because teeth infection can also lead to what? Can also lead to headache. So once you have done this thing, then you go for neurological examination. Of course, like in that one, first we see either there's a confusion. So confusion with acute headache, subarachnoid hemorrhage, meningitis, or dementia, intracranial tumor can be there. Okay. So if you're doing neurological examination, of course you will do the cranial nerve examination. In the cranial nerve examination, the eye examination is very important. Papilloedema, which is a hallmark of increased intracranial pressure. Okay. So this thing. So we go for all the cranial nerve examinations. Progressive oculomotor nerve palsy, especially in pupillary dilatation, which means like there are posterior communicating artery aneurysm can be there. Motor examination should be done for the signs of stroke, for example. Okay. Or for any focal neurological deficit, which can tell you that maybe there can be a tumor, a abscess, a trauma, a hematoma, a hemorrhage, a collection of blood, or any mass occupying lesion. I love this term of mass occupying lesion. Sensory examination will again exclude all these things. Okay. So patient with primary headaches like tension headache, cluster headaches, migraine, they have typically have many years of similar headaches, often starting at young age, and new onset of headache after 50 years of age and less than 5 years of age. Or onset of a new type of headache suggests a secondary headache, and of course they should be tested. Okay, so this is how the flowchart is in the hospitals, how we deal with that then. So remember, anyone, see, you can see the red flags. Anyone you found papilloedema, you will found altered level of consciousness, you found fever, you found the signs of meningism, you found a focal neurological deficit, you found signs of trauma, go for testing. Okay. So detailed history and examination, any red flags present? No. Consider primary headache, are there atypical features? No. Diagnose the primary headache disorder, right? So this is how we move, guys, in this one. So tension type headache is the most common one. 70% of the time it is tension headache. The second most common cause of death is not headache, is migraine. And I'm talking about the primary headaches. Of course, secondary headaches we treat the secondary issues. The most common cause of headache is tension type. The second most common is migraine. The third one is cluster. Now, to tell you a few of the features, uh, you can say primary headaches. A quick uh, discussion. Tension headache, most common. Migraine, second most common. Cluster, less than 1%. Now I will tell you, tension headache, mostly females are the one who are affected with this one. And they are basically young adults, less than 40 years of age. You will not find any family history. It is a band-like headache all over the head. The duration is from minutes to days. It is worse in the afternoon times, evening times. The severity is not so severe, it is mild to moderate. Okay. Provoking factors are depression, anxiety, hunger, sleep deprivation, and relieving factors is rest. And you will not find any other associated problems. So, how you will treat them? Simply give them stress relieving, ask them to do meditation, heat massage they can do, tell them how to leave stress, and if they are doing overwork, they are stressed, try to deal with that and things like this. And just follow the WHO ladder of pain. Just because it's mild pain, give them paracetamol, give them simple analgesics, give them like aspirin, things like this. Sometimes, if it is not controlled by that way, then we can give them tricyclic antidepressants, because many of the people who have tension headache, they are depressed as well. They have depression as well. Migraine, we are going to discuss in very, very, very much detail. Now, tension headache, more common in females. Cluster headaches, more common in males. Young adults, 20 to 40 years of age. Now, this one, migraine is strongly have a strong family history. This one, no family history. This one, it runs in families, but there is not much or too much correlation. Now, this pain, as I told you, is retroorbital. I have seen the patients of this one. One of my friend had this thing, and whenever this pain starts, it is really painful. It will make the person cry, okay? And it comes in clusters. Whenever the pain starts, it stays for from 10 minutes to 2 hours, okay? And there is daily attacks for weeks or months, okay? Either early in the morning or late in the night, and then it goes away. It's a stabbing type of pain. The person you will find, he will be holding his eye, and the pain is constant type of stabbing type of pain. It is so severe that it can wake you up from sleep. Okay, light and alcohol is aggravating factors or precipitating factors, and you will find the patients holding their eye and walking around, because walking is relieving factor. Okay, walking is a relieving factor, guys, in this one. So when we examine them, we found their eye is red, watery, and that water, you will find their one side of the nose is runny. Sometimes you can see like unilateral Horner syndrome. So what is the treatment of this one? Remember, oxygen if they are in hospital setting, or we can give them sumatriptan. Sumatriptan. Okay, and if the pain is like coming again and again, then we can do some prophylaxis drugs like calcium channel blockers, lithium, prednisolone, the same drugs which we use for migraine. So now, guys, the thing is, I told you the features of meningeal irritation. I told you the features of increased intracranial pressure. I told you uh, the last thing which we can discuss is migraine. Okay, and it is very, very, very interesting. So migraine is a primary headache. It's a chronic neurological disorder characterized by moderate to severe pains. Typical migraine is unilateral and pulsating in nature and lasting for 4 to 72 hours. Migraine affect most of the females, less males, and I told you young adults and a strong family history. Okay, will be there. Okay, guys, before going to the classification, I will tell you what is the diagnostic criteria of common migraine. Okay, sorry, wait. Okay, common migraine. Common migraine is diagnosed as anyone who have five or more than five attacks fulfilling each of the following criteria. The first criteria is the pain should be 4 to 72 hours duration. Okay. The second criteria is two of the following: unilateral, pulsating, moderate to severe in severity, and aggravated by routine physical activity. And one of the following: nausea or vomiting, photophobia, phonophobia. Okay. Now see, anyone whose pain is have five or more than five attacks which have each of these criteria. Okay. The pain should be from 4 to 72 hours. Number one, there should be from all these at least two are present, and from these at least one is present. Okay. So anyone who is fulfilling this criteria, we say that the patient have common migraine. Okay. Now, guys, what is the pathophysiology of the migraine? No one knows. There are just theories. For example, there is a theory of some genetic contribution. There is theory of depolarizing wave of cortical spreading depression, uh, like from occipital lobe. There is like spreading depression all over the brain, and there is stretch in the veins, and that's why there is pain. There is a lot of theories. None of them is proved, but what we know that there are many triggers or many things which can cause migraine. Okay, so certain triggers are there. Okay, sorry, yes, triggers. Okay, so stress, sleep excess, or deprivation. Remember, both can cause deprivation. Menstruation, and remember, from menstruation even drugs can cause, like estrogen. Okay, hormonal changes means menstruation. One of the things which is not written over here is caffeine withdrawal. The people who drink too much coffee, when they stop taking them, chocolates, guys, and tyramines. Tyramines are present in the red wine, if you don't know. Okay, and many people, they have through the processed meat as well. They have nitrites. Okay, These are the triggers of migraine, proven triggers present in different people. So, these are, there is migraine without aura, there is migraine with aura, there is childhood periodic syndromes that are commonly precursors of migraine, there is retinal migraine, there is complication of migraine, there is probable migraine. I will explain you these things in very, very, very easy ways. Even there is menstrual, 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 sorry for spelling, menstrual migraine, right? Okay, there is menstrual migraine. So there are many, many, many types of migraines, right? So very easy to remember, guys. I will tell you here. Okay, clinical features, easy concept. There is one thing. What are the stages of migraine? Okay, whenever anyone have migraine, how it goes. By the way, the first thing is called as prodrome. Okay, then there is aura, then there is headache, and the last one is postdrome. Okay, same like viral infections that there is predrome and prodrome or postdrome. So what is prodrome? Now many people before starting of migraine they feel they have some changes, like some people have appetite changes, some people have autonomic symptoms, some people have altered mood, some people have psychomotor retardation or psychomotor agitation, things like this. I'm talking about the stages, I'm not talking about the classification now. If you will understand these stages carefully, you will understand each and everything. What is aura? Aura can be defined as reversible symptoms or simply fully reversible symptoms of cerebral dysfunction which last less than 60 minutes. For example, an aura can only occur in small percentage. Okay, leave this thing. See, aura can be uh, visual, can be somatosensory, can be other symptoms, okay, can be other types of aura. For example, many people they have before starting of the headache and migraine, they have a visual aura, which is the most common as well. See, this is a fort, and see how they are seeing. They are seeing zigzag lines on that, whereas this person is seeing some distortion in the image. Okay, visual aura is the most common type. So they have some visual abnormalities. Okay, visual aura is the most common one. So many people they see zigzag lines, many people they see scotomas, okay, or spots. Many people they feel, see, some people have positive scotoma, like there is addition of something. Some people have what you can say loss of vision from one side, and there can be somatosensory aura, like they feel some uh, sensory changes, like feelings of pin and needles, okay, or paresthesia around the face, lips, and tongue. So aura, or there can be other symptoms, gustatory, auditory, olfactory aura. So these are simply symptoms which basically uh, comes. So see, like there is a patient, for example, he have some appetite changes for 1 2 days and some mood changes. Then he started having some visual disturbances or some sensation changes, and then the headache started. And once the headache started, when it finished, then they have again the same symptoms, which is prodrome and postdrome have almost the same appetite changes, mood changes, and all this stuff, right? So now you can see over here aura. This is the discussion of aura. Okay. Then this slide is talking about pain. I already talked about the features of common migraine. Same thing, nothing new. I already talked about the triggers. When you will take the history, you will ask about the triggers. And again, this is the criteria, but I give you a easy criteria. Both are somehow same. Okay. So this one is like diagnostic criteria without aura. This is diagnostic criteria with aura. So I will give you now the classification, guys. Very easy classification. Very easy classification I'm going to give you now is classification of migraines. Okay. Common migraine. I started my story from common migraine, and I told you the diagnostic criteria of common migraine, right? When we say that the patient have common migraine, when the patient have no aura, this is not present. When anyone have migraine, all other features are there, but there is no aura, we call the patient have common migraine. Then there is a term called as classic migraine. When we say when the have a patient have a classic migraine, anyone who have aura. Okay. So this aura, simply the headache starts with aura, and the aura lasts less than 60 minutes. That is the definition of aura. It is completely reversible symptoms which last less than 60 minutes. Then there is a migraine called as complicated migraine. Okay. Now these are the people when they have the migraine onset, they have severe or persistent sensory motor deficits. Okay, some neurological. For example, one of the migraine which is a subtype of complicated migraine is called as basilar type migraine. Now what is basilar type, guys? Like the brainstem. So simply whenever there is stroke in the brainstem, when we will study stroke, you would know that people had the symptoms like diplopia, vertigo, ataxia, okay, things like this. So simply when they have features or when they have pain headache with these features, we call it as it is basilar type migraine. For example, many people they have hemiplegic migraine. Okay, of course, like there is paralysis of half of the body, or hemisensory migraine, in which they have what, sensory loss in half of the body, or many of the people they have ophthalmologic, ophthalmoplegic, ophthalmoplegic migraine. They have symptoms with the eye. And the last type of migraine is called as acephalgic, acephalgic migraine. The other name of this one is also called as migraine equivalent. Right? Now, what is this? This is very interesting. These are the patients who have aura without headache. Interesting, right? When there is aura without headache, we call it as acephalgic migraine. Okay. So this is the classification of migraine. I believe like it's the easiest classification you guys can remember. Anyhow, guys, The diagnostic criteria I told you, remember, migraine is a clinical disorder, clinical diagnosis. Migraine is a clinical diagnosis. Migraine is a clinical diagnosis. Remember this thing, guys. You know the criteria, you diagnose the migraine. Now, how to treat migraine? I would rather use how to manage the migraine. Uh, this is the treatment for acute migraine attack. But before that, I want to add one point, which is a very, very, very important point. I'm sorry. Wait. The most important point I want to add, I have to add a slide for that. Management. First of all, educate the patient, explain the condition, ask them to see if they can found the triggering factor. If they can found the triggering factor, avoid the triggers. Avoid the triggers, okay? So this thing is very important. First of all, ask them, avoid the triggers. Now, there are treatment for acute migraine attacks. You can see over here, what you can say, NSAIDs are there, alkaloids are there, which are contraindicated in patients with hypertension or cardiac disease, and 5-HT agonists are there, or triptans are there, right? Then there is prophylactic treatment. These are all prophylaxis. I will tell you the treatment over here. Any patient who have mild to moderate symptoms, okay? Give them simple or the first line drugs. First line drugs are which one? NSAIDs. Give them first line drugs like NSAIDs, that's it. Okay. Ibuprofen can be given, okay? Anyone who have moderate to severe migraine, okay, or symptoms, triptans, 5-HT agonists, you know, they are the most effective drugs. Okay, these are the most effective drugs, guys. We can give ergots. I'm not saying we cannot give, but like triptans are the most effective, right? Many people, you know, when they present in emergencies, you know, and they have like a onset of migraine, you know, you will find them in too much pain, they are too much disturbed. Many of them, they are not like doing nausea and vomiting and nausea is there, which is one of the diagnostic criteria of common migraine. So we call them as severe migraine. So we can also give them in severe cases with nausea and vomiting, give them IV antiemetics. Okay, like which drugs, you know, chlorpromazine, prochlorperazine, all those drugs can be given. So many patients, you know, in which like migraine is a chronic problem, and we can give them prophylactic medications. For example, someone who have a frequent attacks more than one per week, and of course it is too much like disturbing, and for the whom the alkaloids used for the acute treatment are poorly tolerated or contraindicated, then of course we can give them prophylactic medications. Propanolol, metoprolol, amitriptyline, venlafaxine, valproate, topiramate, gabapentin, verapamil, many drugs are there for prophylaxis, right? And they are written like how we can, in which cases we cannot give them these things, okay? So this is the treatment of migraine. I already talked about the cluster headaches, guys. I told you, very common in males, 20 to 40 years of age, and like they can occur for more than one per day. Unilateral behind eyes, reach maximum intensity over a few minutes and last for less than 3 hours, okay? And see, Horner syndrome, drooped eyelids, okay, and all those things. And of course, when there is too much watery eye, of course, like they are going to drain from you from the nose. Okay, so rhinorrhea can be there. Unilateral. I told you it is commonly precipitated by alcohol. By like I have seen one of the patient, my close friend, and whenever he wake up in the, you can say after in evenings, he had that headache, which is too much bad for him. Pathophysiology, the exact pathophysiology is not known, but there is genetic predisposition and aseptic inflammation, the cavernous sinus, uh, one of the thing. Okay, so again, this is the diagnostic criteria. I already explained the features, guys. Okay, and it is more common in males. It whenever it comes, it stays for few days. Okay, disturb the patient like for few days or weeks, and then it goes away. The patient become completely fine. No more issues are there. Tension type headache. I'm just scrolling down this PPT just to show you all the things which I've already discussed. Okay, so this one is like in late PMs, right? After the office timings. Band like, very common in females, less common in males. So now, whenever like these tension headaches patients come, we ask them, first of all, we tell them how to, we found like any stressors in their life. If we found any stressors, we try to ask them to avoid them, avoid the stressors, very important. Meditation, many of these people you will found like they are overworked, they are working beyond their capacity, and that's why they become too much, you can say, exhausted. And many of the people, they have financial problems. By the way, in developed countries, they can solve that thing. If someone have family issues, we can discuss that thing also with them. So things like this. So this is how these things are, this thing can be managed. So I hope you guys enjoy this lecture, and I don't think so I miss anything in this lecture of headache. Okay, think about whenever you are going to take history, think about, uh, if you want to, if you can remember some mnemonic, you can remember, like you can use that. Otherwise, think about the most severe, most common causes, and then think about all the structures on the face, forehead, giant cell arteritis, eyes, remember sinuses, remember teeth, remember temporomandibular joint, remember ears, remember the neck. And once you find that you cannot find any things, then think about the systemic causes. Okay, because see, we have headache when we have fever, a systemic thing. Infective endocarditis can give, not infective, like just infective endocarditis, like anything. Infective endocarditis can also give an abscess, by the way. Okay, so think about all the causes, and think about the causes which you cannot see, which are in the brain. Think about the tumors, mass occupying lesions, hematomas, hemorrhages, infections, meningitis, encephalitis, and whatever. When you are going to do examination, what are the your differential diagnosis? You have to see the things on the examination. If your differential diagnosis is infection, you will do Kernick sign, then Brudzinski sign, and head jolt, accentuation of the headache, and all these things. All the signs you are going to see in the patient. Okay, and uh, again, it's a homework for you. Read about ergot alkaloids, read about sumatriptans, and read about what are the indications and contraindications, plus the side effects. Okay, it will help you a lot. And also check the WHO letter of pain, though that is not applied in the headache, but I think very important to see, and very informative thing to read about. Okay, so see you guys in the next lecture. Thank you so much for listening. I hope all of you are safe.